You are welcome to Nursing 342 Medical Surgical Conditions in Childhood. Today we are on session 1 and we are looking at endocrine disorders. For our sessional overview, endocrine disorders occur when we have imbalances in hormonal levels in the blood. And this session, students will be introduced to diabetes mellitus, goiter, hypo and hyperthyroidism. And we'll have to read Wong's Essential Pediatric, which is a textbook recommended for this course to enhance our understanding. Outline, we'll be looking at diabetes, goiter, hypothyroidism, and hyperthyroidism. Topic 1, diabetes mellitus. Diabetes mellitus is a serious and costly disease that affects or is increasingly affecting our young children worldwide today. And this is also associated with serious complications that affect many body organs, including the kidneys, the cardiovascular system, the eyes, and the rest of them. However, with early diagnosis and timely treatment, some of these complications are delayed, and our young people are able to lead near normal lives. Diabetes mellitus, by definition, is a group of diseases characterized by high level of blood glucose due to defects in insulin production or both. Prevalence. If you look at the graph that I have exhibited here, with children under 10 years, you see from literature that 100% of diabetes that they have is type 1. That is an autoimmune infection that destroys the islets of Langerhans of the pancreas, which is the secreting cells of insulin in the pancreas. However, when you come to children over 10 years, you see from the key of our graph here that 95% are type 2, which is mostly related to lifestyle in terms of nutrition, sedentary lifestyle, and obesity. Now we'll look at type 1 diabetes. Type 1 diabetes occurs suddenly and most of the time is very acute and may present with ketoacidosis as a result of breakdown of fat metabolism. And when this happens and there are high levels of breakdown of fat and depletion of insulin gets worse, then most of the time it will result in diabetic ketoacidosis. However, when it starts, the individual may also exhibit some levels of post-meal hyperglycemia, which may progress rapidly to ketoacidosis, especially in stressful situations. Clinical manifestations, as we said, because of the sudden acute nature of it, children with type 1 diabetes are often able to tell you when they had the condition because it happens very acutely and they are also very ill. And also, because they also have high levels of hyperglycemia, most of the clinical manifestations as exhibited on the screen are mostly due to the hyperglycemia, high levels of glucose in the blood. So they have increased tests, which we are calling polydipsia. They urinate frequently or frequent mituration, which we are calling polyuria, weight loss, blood vision, and the like, which you already know. And then also we are saying that when these continue, as I said, and the insulin level worsens and it goes untreated, it results in diabetic ketoacidosis. And here you have the ketones excreted in urine and also in the breath. So you have them exhibiting shortness of breath, abdominal pain, vomiting, and worsening dehydration. And then also there is elevation in the blood glucose. Acidosis, if when not treated, will result in coma. And also, often children have, in this condition, the differential diagnosis is gastroenteritis because they will exhibit abdominal pains, and you may often, or it's often leads to us diagnosing this wrongly, because when they have the abdominal pains, most of the time it is seemed to be gastroenteritis, whereas most of the time it is not. Because then the additional thing that should inform you is that apart from the gastroenteritis symptoms that the child may exhibit, there will be frequent micturition, which should lead, and vomiting, which should prompt you to suspect the possibility of type 1 diabetes. So when we're looking at the cause, we're saying that it is all as a result of distraction of the islet cells of Langerhans in the pancreas that causes this. And this, most of the time, can be inherited or can be acquired as a result of some factors in the environment. So, goal of management. The goal of our management in the care of the child with diabetes or any other diabetic patient is that we want to achieve near normal levels of glucose and prevent the development of complications. So, management at diagnosis. When the child is first diagnosed with diabetes, we have said that our goal is that we want to achieve near normal values. So education must go on so that the individual can also live an independent life, because this is a chronic infection that the child will go back home. So a lot of education must go to the child and the parents or the caregiver on healthy eating habits. And here we are talking about reducing the amount of food most of the time, because there is a problem with carbohydrate metabolism. The dietitian must be called on board to come and help. And there is also the need to talk about daily physical activity, because with increased activity, especially exercises, help with the utilization of metabolism of glucose. Also, this is also very dicey, because we have to teach the child to know how much he can take and what to do to prevent him or herself from going into hypoglycemia. We'll be discussing this further, and there are some special issues that concerns the diabetic child. Insulin medication, especially in type 1 diabetes, we give insulin injection. So all these things come on board in terms of teaching the child how to give the injection, and then self-monitoring. We encourage the family to have their own monitoring, a glucometer for monitoring at home, and they will be taught in the normal values so that they will be within the normal values as much as possible. So we'll continue to talk about providing nutritional therapy. We said that here the dietitian must come in, and the nutrition requirement is based on the growing needs of the child, and also issues to do with some adolescents, because the adolescent is also known to try to experiment. And this is the time that they follow fashion and would like to eat all manner of foods. But when they know better, they will do better. So we have to also look at some behavioral issue that surrounds the diet of the adolescent and giving the necessary education, because we know that they have to avoid empty caloric foods. That is fruit juices, the Coca-Cola and the Fantas. All these must be avoided. The eating of ice creams, which they may usually like to take at parties. All these will be taught when the dietitian comes in. And there is also the need to conduct or bring on board the psychologists, so we can together work with the psychosocial challenges and the emotional challenges and some behavioral disorders, especially that will be exhibited because this child will feel special and sometimes stigmatized in society. And there is also the need to check ketone bodies, because we have said that when there is depletion in glucose and also some amount of fat metabolism, ketone bodies come up and may lead to diabetic ketoacidosis. There is also the need to perform eye screening periodically, if it's every 3 months as recommended standardly, or every 6 months, depending on the policy in the hospital. But ideally, at least twice in a year, a child with diabetes should have the eye test. And also, when we come to quarterly follow-ups, it is very, very important that children with diabetes have reviews every 3 months. And at each visit, we have to examine the glycosylated hemoglobin, which is an indicator of the average glucose over 3 months, so that sometimes when it is getting to time for the child to come to hospital, then they will try and do all that they can do the best. So they will come in with very normal fasting blood sugars, but the glycosylated hemoglobin level will give us indicator of their glucose level or blood glucose over 3 months and give us a true indication of how well controlled their sugars are. And also we have to check their BMI and also blood pressure. The injection site must be examined for any signs of infection for early identification and treatment, and also go over other things that we need to promote their health. Annually, we should evaluate their nutritional therapy, find out how much they are having, what they are eating, and also provide ophthalmic examination and perform thyroid function tests and examine their feet so that if there is any ulcer developing, it will be identified early, and all these is geared towards preventing complications. Type 2 diabetes. We're saying that more and more children worldwide are having this diabetes as a result of lifestyle, and also resulting because of insulin resistance, because children are becoming very obese and are having more than the insulin secreted their bodies can be used, can be taken care of. So when this diabetes sets in, usually at the beginning, it will have very high levels, and then with time, as the pancreas cells or pancreatic cells get destroyed, then over time, diabetes or type 2 diabetes sets in. So it is important, as you may already know, that the development occurs very slowly in type 2 diabetes. And our main aim is also to develop near normal values in our management. And some of the clinical manifestations that the child may exhibit are most of the time similar to what the children with type 1 diabetes do exhibit. However, it is important to note that some type 2 diabetics may show no symptoms at all, and still others may show some symptoms like blurred vision, frequent vaginal infections, and then burning sensation on micturition, which most of the time is due to yeast infection. So it's important to investigate further when children come to the hospital with some of these complaints. And also, other children may also exhibit high levels of blood glucose, which is usually associated with dehydration and may lead to coma, because sometimes diabetic ketoacidosis may set in. And some risk factors we have to consider that in type 2 diabetes. We are saying that obesity is a key indicator. So when the child is overweight and the BMI, which is weight in kilogram over height in meter squared when evaluated, is more than 85 or more than the 85th centile. In addition to that, any of the following risk factors may add up: a family history of type 2 diabetes, or the child having other conditions that are associated with insulin resistance, such as hypertension or acanthosis nigricans, what you may see as black mark on the skin of some children, or some skin deformities. There are schools of thought concerning this. Some schools of thought say that it may not be very significant. However, literature still says that it may be a risk factor to consider in children who may come with overweight, and also children who may have the history of small for gestational age or maternal history of gestational diabetes in pregnancy. So it's very, very important that we take our histories properly to assess and make sure that these are not overlooked. So test criteria. When do we start testing children or assessing for the possibility of diabetes? We have said that in children more than 10 years and over who are obese, 100% are from obesity. So above age 10, it's time to also looking at these. Or if the child is an early maturer and puberty sets in early, then maybe you may go beyond age 10 and start at age 9. And also, frequent testing, we should do this every 3 years. And also, the test we must look at is the fasting blood, the glycosylated hemoglobin, and then 2-hour glucose tolerance tests may be considered under these. And then some clinical judgment may be needed in cases where some of these, the child may be presenting certain symptoms. So we have to look at all these. Management. Our cornerstone of our management in type 2 diabetes is the diet, physical activity. And we have said that in children with type 2 diabetes, the drug of choice is metformin. Even though there are lots of drugs that have been produced for adults, a lot of them are contraindicated in children. So the first line drug is metformin. However, in cases where they don't do well on metformin, then there may be the need to add insulin injection. So it's very, very important that we nurses are aware of these things. And also, it is recommended that we check the blood pressure, because sometimes there may be an underlying hypertension. So it is very, very important to note that one of the complications a child with diabetes may have is hypoglycemia. And this is diagnostic when the blood glucose level is less than 2.5 millimole per liter. And sometimes it is very, very important that we take into consideration that when we're giving children insulin, it is very, very important that we give them knowledge on how to take snacks in between meals, and also to note that depending on the type of insulin the child takes, there may be the need to take a meal at a time that the insulin peaks, so that will prevent hypoglycemia. It is also very important that we note that some additional signs and symptoms may be exhibited by the child. And these I have presented on the screen. The child may become irritable and shaky and more. So you can understand this. And in management of hypoglycemia at home, it is important that as soon as the child exhibits any of the signs and symptoms that a child with hypoglycemia is indicated in hypoglycemia, the child is giving a glucose drink that contains up to about 15 grams of glucose. An example of these are fruit juice and all the Coca-Cola and Fantas or empty calorie drinks that are contraindicated in diabetics. But in cases where they have hypoglycemia, this may be indicated. Once more, we have to check the glucose level after 10 or in 10 to 15 minutes to make sure that it is normal. But if not, then it is also important that we repeat giving them the sweetened drink again. And then also, then we have to maintain this if it is normal by giving them a snack or a meal to prevent recurrence of hypoglycemia. And it is also very, very important that in cases where the child cannot drink, then it is indicative that we rush the child to hospital where glucagon is administered. This cannot be done at home. And remember that the brain cannot do without glucose for more than 5 minutes. So in this case, it may be very fatal. Special issues. When it comes to the management of diabetes, it is very, very important that we know that it requires us to integrate certain physical and emotional needs of the child or an adolescent and their family in the management of our patients. Diabetic patients face many challenges, whereas it's normal for any child to attend a party or play any sports at school. When it comes to the diabetic, it needs further consideration. So it is important that the child is educated. When the child has the necessary education, it is said that when you know better, you do better. Because if the child knows they're going to parties and drinking Fanta and other empty caloric and taking other diets in excess will make them sick, then they will be careful. So it's very, very important that the family is educated and the child is also educated. And also when it comes to playing sports, the child will have special needs. Because when it comes to playing sports, the child may have to take some sweetened drinks to prevent him or her from going into hypo. And at the height of the game, the child may have to take a break and take some more so that he doesn't go into hypoglycemia. And then spending holidays with relatives. It is also very, very important that the family he's going to visit. These days, we are talking about sleepovers and the like. It is important that the child is made to understand that with him, this must be treaded cautiously. And the family he's going to visit must be informed so that they take the necessary precaution. And so this is very, very important. Okay, when it also comes to the diabetic child, it is also very, very important that we monitor the cognitive development or skill in terms of their management and correct any deficits they have in terms of giving themselves insulin injection because of the danger of hypoglycemia and then also the danger of having excess levels of or hyperglycemia, as we may term it, because it may tip them into diabetic ketoacidosis and then severe dehydration that is associated with hyperglycemia and may tip them into coma. So the healthcare team must also make sure that the child gains independence gradually, because this is a chronic condition that the child is going to live with the rest of his or her life. So we need to teach them and prepare them so that they can adequately care for themselves by the age of 15 and above, where they may be going to senior high school, which may require them to leave home and live in boarding facilities. So we need to prepare them adequately. If not, the transition, if not properly planned, may lead to some dangers or complications at this age. So here we have some activity. Let's get thinking. Kofi, a 10-year-old boy, is a diabetic and loves football and wants to join the school team at the intersectional sports. From your understanding of diabetes, do you think Kofi should be allowed? What precautions should be taken? Take time to ponder over this and come out with some answers. In your group discussion, try and discuss this. I think we'll consider this under special issues. You read further and then answer this very, very well. Topic 2, goiter. we see that thyroid disorders are common worldwide. In Africa, iodine deficiency is a major cause of thyroid diseases. Although universal salt iodization programs have been successful in some African countries, the prevalence of iron deficiency remains high and its devastating effects are very common among children in Africa. The thyroid gland regulates the metabolism and intellectual functions. Therefore, it is important that we discuss how to prevent and manage some malfunctions of this important gland. Endemic goiter. As you can see from this Yoruba statue that was carved in 19th century, it therefore suggests that the problem of goiter is very, very old in our society. And it even has its name in many local dialects. Among the accounts, they call it compo and the like. And also, there is compelling evidence that this is a problem that stems out of dietary deficiency of iodine. So, goiter, to a large extent, is endemic in many African countries due to iodine deficiency in most of these places. And this is commonly found in communities where crops are grown in soil that are deficient in iodine because they've been eroded. Poor farming practices and the like have led to leaching or erosion of iodine from the soil. Another is lack of access to iodine-rich seafoods, especially in regions that are far from the sea, and they eat mostly fish from the river. And children and pregnant women are mostly affected, and communities practically, there are some examples of some communities that practically almost every pregnant woman has goiter. And this was found in a study done by Thyroid Universal in Central Africa. So iodine deficiency disorders in children include goiter, which is mostly enlargement of the gland, hypothyroidism, cretinism, mental impairment, and infant mortality, among others. So in Africa, it is estimated that especially, according to UNICEF 2013, it says that the prevalence of iodine deficiency in Africa is 42%, and 80% of newborns in Africa are exposed to learning disabilities arising from iodine deficiency. This tells us that the impact is very, very grave on our children. So as a result, we have had these iodine deficiencies in Africa. Attempts have been made by governments in many countries to correct these by going for a universal program where most of our foods, especially our salts, are fortified with salt. However, in some African countries, research has indicated that because of unregulation of the fortification, some are also exposed to excessive iodine levels in their diet. So there is a need for government and policy enforcers to make sure that things are done properly, because either side of the coin is dangerous. Now we'll look at topic 3, hypothyroidism. Hypothyroidism results from deficiency or less circulating levels of thyroid hormone, and this results in cretinism, where it's left untreated. And then the etiology, we are saying that in many times it can be congenital, or hypothyroidism can be acquired. So this is an example of a newborn with hypothyroidism. Looking at the picture, you see that sometimes some children may not exhibit any symptoms at all, but others may have. What do you see in this child? take time to look at it carefully. As we progress, we'll be looking at some of the symptoms. So keep your guess on your paper, and then as we go to the symptoms, you see whether you got something or not. So congenital due to absence of the thyroid gland, which is thyroid agenesis, or dysgenesis, where there is some malformation, or iodine deficiency from the diet, defects in thyroid hormone synthesis, defects in the receptors, maternal thyroid antibodies crossing the placenta, or as a result of drug that the mother takes. An example is carbimazole. So, acquired or juvenile hypothyroidism, we have said that can also occur as a result of autoimmune thyroiditis, which is also referred to as Hashimoto's disease, where there is chronic autoimmune inflammation of the thyroid gland. It must also be as a result of many other factors in the environment, or even as a result of thyroidectomy, where there is surgical excision of the thyroid gland. Clinical manifestations. Overt symptoms may not be present at birth. I've said that already. And we are saying that some children may exhibit some symptoms. An example are marked open posterior fontanelle and white sutures. The child may be weak and lethargic at birth, sluggish, and the tone of muscle may be very weak, so resulting in hypothermia. And hoarse cry. When the baby cries, you hear very hoarse or deep voice. Difficulty in feeding, constipation, abdominal distension, and the like. I'm sure you exhibited a few of these in the picture shown earlier. Cretinism. We're saying that it results when hypothyroidism, our congenital hypothyroidism, is left untreated. In the picture, you see 4 young ladies, 3 of them with cretinism, and the other one standing in the background are all of the same age. That tells you that in the types, when we talk about myxedematous cretinism, it has to do with growth retardation, and then the neurologic cretinism. When it comes to endemic goiter, we are saying that there are 2 subtypes, as I have mentioned earlier, and then the myxedematous variety is what you saw in the picture in the children with protruding abdomen. In Central Africa, there are some communities where 25% of the children in the endemic area were all affected with myxedematous variety. That is not to say that neurologic subtype is not common. It is also prevalent, and this has to do with mental underdevelopment. So it also results in severe mental retardation and deficiency, and you may have deaf mutism and then limb spasticity and other things. So it's very, very important that we address these problems early. So when it comes to the management, lifelong thyroid replacement is what is done to abolish the signs and symptoms of hypothyroidism. When this is done, then the prognosis is good because you are able to re-establish normal physical and mental development. The drug of choice is normally synthetic thyroxine, and an example is the levothyroxine. The prognosis, I said, is good if diagnosed early, and children have normal physical and mental development. Nursing management. Our key objective is early identification and ensure that thorough neonatal assessment is done at birth. And in follow-up examination about a week after delivery at the postnatal, the examination must again be thorough for early identification. Nurses need to be aware of the earlier signs of the disorder. And these include prolonged jaundice, constipation. We talked about umbilical hernia and protruding abdomen. These are suggestive of hypothyroidism. Prenatal education and compliance with treatment will also be very, very important to prevent complications. Also, we should encourage parents to camouflage drugs when identified, and it's difficult for children to take it, so that if it is the porridge or orange juice or whatever is available, you add it and give it. And also, if the drug is missed twice in a row, it should be given the next day. Encourage breastfeeding in hypothyroidism, and encourage parents of signs of overdosing. And when we overdose the children with the drug, it may result in rapid pulse, insomnia, weight loss, and the like. And genetic counseling is also very important in this case, in cases where there is family history, because this is inherited in autosomal recessive manner. Now we'll look at our third topic, which is hyperthyroidism in children. We are saying that hyperthyroidism refers to activity of the thyroid gland, which leads to excessive release of thyroid hormone, and consequently is accelerated metabolism and in peripheral tissue. And here you see that the children causes a vast majority of grave disease. So hyperthyroidism is rare in children. So most of the time when this happens, it's as a result of Graves' disease. So when it comes to hyperthyroidism, the prognosis is good because there are numerous therapeutic options available. So if identified early, we are able to treat it. And there is also the danger that we must note of hypothyroidism. So the drug, in terms of how the drug should be administered to the child, should be done well to prevent some of these things. So when it comes to hyperthyroidism, they are saying that it is rare in children, and the cause, 95% of the case, is as a result of Graves' disease. However, toxic adenoma, toxic lobular goiter, subcutaneous viral thyroiditis, and other bacterial thyroiditis and more can lead to this condition. However, we should not lose sight of the fact that in early stages is as a result of Hypoglycaemia, and we have said that it is the chronic inflammatory condition of the thyroid gland. Diagnosis. The diagnosis is based on thorough history taking. So we must not underestimate the importance of taking our history properly. And this reveals exposure of goitrogens, especially in the diet, and also increased level of T4 and T3. And also there is also the suppression of thyroid stimulating hormone in the levels of blood estimated. And cardinal signs that we may see here are physical restlessness and also decelerated school performance or poor school performance, and also very big appetite because of high levels of the thyroid stimulating hormone, which we said regulates metabolism, so there is high need for food. And then some physical manifest signs we may see here is tachycardia. There is also widened pulse pressure, tremor, goiter, and many more as seen on the slide here. And we have said that in our management, our aim is to retard the rates of hormone secretion. So 3 acceptable methods are used, as seen on the slide. And one among them will be subtotal thyroidectomy or maybe surgery and the like. And so there are effective methods available, and this must be taken note of. Thyrotoxicosis, we're saying that it is rare and the prognosis is good. However, when we have children having thyroid crisis, in cases where these occurs suddenly with high release of thyroid stimulating hormone into the blood, it trips the children in crisis, what we call thyroid storm. And some of the symptoms are what I have put on the screen. We have severe tachycardia, severe restlessness, vomiting, hyperthermia, and coma or even death in severe cases. Nursing management, identification of children with hyperthyroidism early and provide quiet and unstimulated environment in the hospital. We should group all our nursing care so that we promote rest and also encourage wearing of light clothing, because we have said that here the child has high metabolic rate and so may be feeling very uncomfortable because of the hyperthermia that this may result in. And there is also the need to educate parents on the drug regime and teach and promote identification of any reaction such as hypothyroidism. This is the end of our lecture, and these are some references that you can read from our textbook or any other pediatric textbook that discusses the condition. This brings us to the end of our session on endocrine disorders.